All right, let's get to the front slide. That would be great. Okay, everybody, I guess we'll get started, and whoever joins us, we'll just jump in. All right, so welcome to our long-term care Project ECHO Learning Action Network. Next slide. Okay, and just a thank you to HAH, to Mountain Pacific, United Healthcare, Aloha Care, as well as HRSA for making this series possible. This is a collaborative educational partnership. And we are committed to maintain confidentiality. So anything that you share should be HIPAA compliant. And also we want to make sure this is a safe learning environment. And we want to foster sharing and learning, mutual learning and encouragement. And, you know, no need to feel embarrassed or negative, feeling shame or blame. And in fact, we're going to encourage you that even if you want to chat, feel free to chat in the box to everybody, but if you want to keep it more private, feel free to private chat your questions to any one of us, me, Dr. Takenaka, Michaela, and we can certainly just read your question or comment without your name attached to that. Next slide. Okay, these are just some of our objectives for running this ECHO, you know, for basically talking a little bit about COVID recovery, practicing age-friendly health systems and some QI strategies, as well as some regulatory updates for quality measures in COVID. Next slide. These are instructions for receiving CMEs. You need to complete, after your registration, complete an evaluation. Right after the session, it will go up in the chat box where you click on, you complete it right away. And then you can get your CMEs and CEs, as well as social work CEs. Next. Okay, so this is just to remind you that actually HRSA is encouraging nursing facilities to adopt age-friendly health systems. Of course, that's what our whole series is about. And we've covered mentation, we're doing what matters, and eventually we're going to do these other two as well. There will be an opportunity for age-friendly health systems recognitions for nursing facilities coming up through the Institute for Healthcare Improvement. We'll give you more details on that a little bit later as we have more information on how to support you through that. So stay tuned. I just wanted to mention it so you can have your heads up on that one. Next slide. And this is part of the What Matters series. There's 4 parts. Today we are on the second part, part 2, understanding what matters. Next slide. And I just want to introduce our hub team. And me, I'm the course director. We have Dr. Cody Takenaka. She can wave hi. Gail Rodriguez. Not sure, I haven't seen her. But if she's around, she'll join us. Dana Mitchell is unable to join us today. And then Lori Henning. Okay, great. And our speakers report they have no conflicts of interest. Okay, so we're going to jump right in, and Lori, take it away.
Okay, thank you. Well, hi, everybody, and thank you for joining us today. We have been grateful to see the Omicron surge wind down, as I'm sure you have too. So while the risk is still with us and we need to maintain appropriate infection prevention and control precautions, most of us here in Hawaii are not in the critical surge status that we were. We're very grateful for that. So I'm going to share my screen with you and just run through a couple of slides. Okay. So at the end of February, the CDC released a COVID-19 community level tool, which classifies counties into low, medium, or high with recommended prevention measures for each level. And the CDC website did state that that recommendation does not apply to healthcare settings because the consequences of spread and the risk of triggering outbreaks is greater in those settings. So we do know that this written knowledge on their website has been helpful to some healthcare institutions, which were getting inquiries from visitors and family members around the changes in the recommendations, especially regarding the mask guidance, for instance. So If you have that come up, you can refer to their website because they do have it boldly stated there that it is not applying to the healthcare facilities. But the CDC does continue to recommend that healthcare settings, including nursing homes and assisted living communities and their visitors, follow infection prevention and control practices to reduce the risk of transmission of COVID-19. And I've included the link here to the latest updated version of the infection control recommendations for healthcare settings. Okay, so let's take a look at some of our data. So from our Department of Health, we can see that all counties continue to experience a decline in the number of cases. And we are glad to see that. Our total confirmed COVID-19 patients in hospital beds, and this is representative of the state of Hawaii, it does continue to decline. So we're not quite sure where we were before, or we're not quite where we were before the Omicron surge right here, but we're really close. We're getting there. And then as you can see here, the ICU bed usage in the state of Hawaii is back down to pre-Omicron levels. And then this data shows the total new COVID admissions per day. Again, still trending downward, so good news on the COVID front right now. And then this data is taken from last week. So this is February 27th through March 5th. And it shows that Hawaii had the 20th lowest infection rate in the nation. And that's up from being 15th lowest in the prior week. For the duration of the entire pandemic, which they define as March 7th, 2020 through March 5th, 2022, that's the most recent date we have, Hawaii has had the lowest infection rate in the nation. So again, this is just a testament to the hard work that you have done in protecting your residents and maintaining increased IPC standards during this time, and for our community coming together to show aloha and respect towards their neighbor. And the latest statistics from last week show that Hawaii had the 6th lowest death rate in the nation. And as we look at our ranking for the entire duration of the pandemic, Hawaii continues to have had the 2nd lowest death rate in the nation, second only to Vermont. And then as you can see here, an overall look at the pandemic, that's Hawaii's infection rate, and it continues to decline. So last week's rate was 76 per 100,000 individuals, and that's down from 105 per 100,000 individuals in the week before. So it's been a long haul, and I know that everybody is exhausted and tired of talking about COVID-19, but thank you for all you are doing and for caring for our kupuna and for keeping up with the infection control practices to protect the quality of life of those you care for. It really is making a difference. So thank you. And Dr. Wen, I will hand it back to you.
Okay, actually, I'm going to hand it off to Dr. Takenaka, and she's going to talk to us about what matters. Thank you.
So hi, I'm Dr. Takenaka. Maybe I met you guys before on other echoes. I practice nursing home medicine and I teach for the Department of Geriatrics. And we're going to talk about the other M, what matters most, and how to, start the discussion on advanced care planning for our very vulnerable patients. Next slide. So let's start off kind of with an icebreaker to kind of hear your thoughts. Where are we right now in talking about advanced care planning, goals of care with patients and families? Why are they challenging for you guys? Does anybody want to chat to everyone? Or if you're shy, you can chat to me or Michaela. What are some barriers or some challenges that you guys have come across in just initiating or, continuing discussions regarding goals of care or advanced care planning, post forms? For me, I have to start these conversations on the same day that I meet people for the first time quite often. Well, some people don't want to talk about it. It's not the most pleasant thing to talk about. might not be, but it might be on the, the top of their mind. They just haven't had the opportunity for anyone else to bring it up, especially if it's something challenging to bring up with your family. Anybody else have any challenges with these conversations or? Yeah, ooh, the Japanese side of my family said, don't say that kind of stuff. If you talk about dying or death, it was like a bad omen to them sometimes. Sometimes it's cultural, sometimes it's just, your family. Or it induces anxiety if like all of a sudden your doctor is talking about your heart stopping. Why is she bringing this up now? It could be, worrisome. Yeah, it's hard to figure out where to even start. Like, hi, nice to meet you for the first time. We're going to be taking care of you. Welcome to our facility. What do you want to do when you're ready to pass away? It's really hard to segue into like deep, heavy conversations, right? Yeah, it's challenging. Let's move on to the next slide. If you guys think of other stuff, you can just randomly chat it in there. We'll keep checking. We're going to talk about trauma-informed care, and part of beginning discussions and building rapport and trust is also to be aware of what we call trauma-informed care for our patients. And just know when we have lots of different types of people that we take care of in healthcare, that their views on decisions or their perception of the situation where they have to make the decision could have effects from their past or their history, including their experiences. You'll see some people are hesitant to even talk to us in healthcare about specific situations. And that might be because of something that happened to them in the past or even recently in the past exposure to healthcare. And so core principles of being aware about trauma and how it affects patients and their health is to really look at your organization and how do we overall in our organization and our team in a way that we communicate and care for them, make the patients and staff feel both physically and psychologically safe, to be consistent in terms of transparency in the way that we communicate, and to show them how we make decisions, and keep them involved in that discussion. And this is also part of advanced care planning, to say these are the options that are available to you if something gets worse clinically, and I want you to be involved in this decision ahead of time. Peer support, to be able to figure out, if there's, people who have had similar experiences, how to support each other through that, how to make referrals, things like that. Be collaborative with both your patients, your families, and the whole interdisciplinary team. And not so many things is going top down, but to show that you're interested in involving the whole team, including the patient and their families or decision makers. Empowering the patients and the staff to, work with each other to address their trauma, their experiences, and also to support each other through this illness or whatever we're managing them for. And to be responsive to places where we could have weaknesses in our organizations, to always be looking how to improve and evolve our organizations and policies. Next slide. So what is trauma as a definition? Yes, trauma could be what we go to the ER for, but trauma could mean a lot of things for a lot of different people coming from all their different walks of life. That's one of the gifts of being in geriatrics. You just meet so many people from so many backgrounds. It could be individual based on any kind of negative event or experience that happened to them in the past, be it from childhood or even through adulthood. We, also have elders who are abused sometimes. It could come from natural disasters, and many of us have been through so many right now with the past hurricanes that are going all over the place, or, other things that happen in local areas, regional events. My son talked with his 5th grade class about anything that made them fear for their lives in their young 11 years of life experience. And he was able to talk in his class about how scared he was when Hawaii was sent that emergency alert. Poor thing. It's a very local thing, but it was very real for, whatever 10, 15 minutes that was. Culturally, so in Hawaii and everywhere you go in the US, there are so many cultural groups that have endured so much trauma. And for us to be aware that it could be contributing to how they step into the conversation, how they make decisions, or even it could even affect your health because it affects their behaviors for the rest of their life. Next slide. So there are studies, a lot of them are studies right now, evidence of looking at adverse childhood events. That's what ACE stands for. So they looked at adults who had adverse events or trauma events when they were children, and they followed them up after the age of 18 into adulthood, and to see, does this affect their health in adult life? They're more likely to, if you've had a score, so experiences that were higher or more frequent and before age 18, more likely to be smokers, to have chronic obstructive pulmonary disease, alcohol abuse, any kind of street drugs, and to have attempted suicide. It really does affect you in so many arenas in your health. It could even affect, how they present to even primary care, if at all, or utilization of urgent care and EDs. Next slide. So being aware of this is a first step for us in terms of how we approach people to build trust when we start these very, very important conversations, because we're going to be giving them tools to make very important decisions that could really, have a big effect on the rest of their life. So when we talk these conversations with them, think about how we're communicating. Be aware of your body language. And always kind of, I know it's difficult now that we have Zooms, but we're always thinking about social distancing. But, in person, you have to watch how comfortable are they with your type of body language in terms of proximity or just the way you react to the way they talk. Inform the patient who you are and explain what we're going to do, including our conversation, what we plan on talking about, or exams if there's something that we have to do for physical exams so they know what to expect. Do your best to think about how you present yourself in the conversation, and to talk with them like, not I want to talk to you about this, but I wanted to talk with you so we could discuss together a decision. So it's less about something that I, as a healthcare provider, have to do, or we need to check something off a list, but we want to work with you to start thinking about these decisions. Collaborative approach. It's really tough when you're busy, but learn how to pace yourself so that things are not rushed. If you have to explain things one at a time, or even just begin to answer one question, even if it's done well, that's more effective than answering all three of your questions, but they feel rushed, then they feel uncertain about their decisions. Do your best to think about how your reactions or your words about blame or shame or judgments. Often caregivers come to my panel in the nursing home with a lot of burnout or guilt about their loved one being admitted to the nursing home. And I really do my best to coach them through those feelings because it's really challenging to be a caregiver. How to identify their strengths and how to build on them, play up the positives. Don't ignore their needs. So when they are uncertain about things or anxious about things or have questions, make sure you pause to help them address what's their main concern as well. If they're concerned about one thing, about this rash, at least be able to meet their needs before you also ask them to meet your needs, to discuss with them about a decision, and to find a place where it's conducive to a serious conversation. So very, very large Zooms might not be the best arena if you can't get everybody to mute their mute themselves or figure out how to discuss it openly. If you can meet in a place where it's, at least private or allows them to ask questions without you being interrupted by your electronic devices, that helps a lot too. Next slide. A lot of times we have to kind of think first about the big picture. And so it's good to, as an icebreaker, when you start this conversation about advanced care planning, goals of care, or you want to get started on that process to fill out the post form, is to really show that you care about the person and who are they. You ask them, what were they like before? Talk to the patient, their caregivers, their loved ones. Find out what their identity and culture is. And even though they could be presenting as one ethnicity, every person has their own individual culture, and their flavor of culture could be completely different from somebody of the exact same ethnicity that grew in the exact same region because of their own identity and experience. What are their relationships? What do they value in terms of relationships? Who are the important people that you need to talk to? Who do they trust? Which doctors do they trust? That helps, to know what relationships do they also have with other people in the healthcare system. What is their personality like? What are their likes and dislikes? This really helps to put into context, into the big picture of how you would help to paint a picture of what does healthcare look like or treatment look like for this patient if their major health problems go downhill. You can say, well, if her heart failure gets worse and Mrs. So-and-so has a hard time breathing, I know you said that she hated this too, or she really hated it when they did this and this to her for this treatment. I can tell you if I send you to the ER, the first 3 things that they do for someone who has a hard time breathing is 1, 2, 3. And those match up with the exact same things that I know she would really, really not like. What are some other options I can offer to you so we can avoid that situation? So it's helpful to know what they liked or disliked. Next slide. This is a big checklist, but it's really juicy. And the good thing is you'll be able to look at the PowerPoints after this presentation and to think about being culturally appropriate when you talk to people about what matters to them in terms of making decisions about healthcare and how to approach that conversation with them in a culturally sensitive manner. For us, it's really important in a multicultural area like us in Hawaii to know what is their preferred language. And sometimes for a dementia patient, what is their primary language? They can regress back to what was most comfortable to them in their youth sometimes, even if they were super proficient at another language in their adult life. I'm going to regress back to super blala pidgin. And when you guys take care of me when I'm super old and you get a translator for me. And so, what are they comfortable speaking? Even if they were known to be fluent in another language most recently. Talk to, the family about formality or the patient. How do they prefer to be addressed? You often find people who are familiar with each other in Hawaii that will sometimes start to go back to calling each other first names. But you look at their comfort level, or you talk to the patient and family. What should I call you? What do you like? They might be comfortable with something else. And that will help them feel more comfortable in a situation where having an important discussion. Be mindful again of nonverbal communication. As we all get back to more in-person meetings, I find that I have become physically awkward again when I'm talking to people in person. Very strange. We're all socially distancing, but we're also learning how to adjust to, being in the same room as other people again. And, patients and families have different comfort levels for that. Think about, could there be something culturally in their experience or historically in their experience about trusting healthcare. There are many cultures that were done wrong by supposed healthcare systems that were out to, on the surface, help them, but ended up causing some harm in some way historically. And to explore that with them, if you find that you come across a lot of resistance in conversations, you can say, you know, I get the sense that you guys are having a hard time talking about this, or that you're really, you know, you're really uncomfortable when we talk to you about these things. Is there anything that you're concerned about or uncomfortable about? And sometimes they'll tell you. Other times it's just for us to do our homework to learn about other minority populations and what culturally has affected the populations that are more prevalent in our practices. Really knowing their history in terms of trauma, medical problems, or even things that could have gone wrong in other healthcare systems, to really know, you know, even from our side, not on the cultural side, but just in the healthcare system, what has happened with them. We've had patients that have survived complications of things, or have, you know, presented for trauma or injuries of things, and to be able to understand where they're coming from. Why are they so afraid or anxious about certain types of treatments or discussions? I've had patients who've even graduated from hospice. And then how do I explain that I'm talking to the family again about things? It's good to know the background. So you can put it into perspective for them. And really, you know, think about, how does the patient want to make decisions? Not every person is comfortable with the you and me one-on-one conversation. Ask them, how do they want to make important decisions? Who do they feel needs to be there, to be involved? Because sometimes for that person, it might be important to have several other people that they have a relationship with. Next slide. Life context and priorities. This is another great way to kind of segue into the heavy stuff, the answers to your questions, because this gives you a better feeling about, where are we meeting this patient or these families before we help them make big decisions? What's important to them? What are they most concerned about? Where do they find joy? You know, what makes their life worth living? You'll often find patients who will tell me, you know, doc, I really want to live to be, one of them said, oh yeah, her goal is to live to be 100 because her sister lived to be 100, you know, or their goal is to, you know, go back home to their dogs. That was my grandpa's #1 goal. The dogs would wait outside of the door to his bedroom because they didn't know he was in the hospital. And it was a very happy day when they were reunited. And so just to know, where is their joy, where is their priority, so you can help them envision that in terms of, how do we aim our decisions towards this? Even if we can't guarantee that we're going to get there 100%, at least reaching towards that goal. It gives them definitely more of a sense how much you care about them as a person. Not that we make decisions to check off boxes or fix a number or get things done so you can discharge on time. Next slide. Guiding questions. So thinking about treatment goals and preferences. So this is where we're starting off big and very general, like, who are you as a person? And then we get down a little bit more personal to, what makes you happy? Where is your heart? What makes you anxious? What do you like or dislike? And now you focus in a little bit more on the healthcare decisions. So you see how you kind of come a little bit further out here into the universe, and you start to guide the conversation. Really, all of this is an art. And for our geriatric fellows, it takes them a year and sometimes even more to hone their skills on guiding this kind of discussion. It's not often something that you're gonna do in one meeting. It's a process. So it's like building a relationship with that patient or the family. Typically in the nursing home and post-acute care, I can do this over a series of meet you on admission, many phone calls with the family, talking with the patient about what makes them happy, even if they have dementia, relaying that back to the family, talking to the interdisciplinary team. So imagine these questions happening over the course of a conversation. So it's a real process. Everyone has a different timeline. It would be ideal to have decisions as soon as possible when you need them in case something happens. But it's good to kind of think about this as an ongoing process, no matter where you are in terms of the decision. Even after they sign that POLST form, I continue these discussions. And so these are questions a little bit more about what do you want to happen if things get worse? I'm concerned about this specific thing happening because I know this health problem is not great. So I'll say, what do you want me to do if the pneumonia comes back? What would you want to happen? What do you worry about? Most of us in our experience, or you can talk with the rest of the team, they can tell you when you review a patient case, what are they concerned about going wrong? So you can kind of pose that to your patient. You can make it a sandwich and be like, good news, this something positive is happening. We also want to plan just in case something happens. We're concerned, what if this goes wrong? You know, we also want to be prepared because we know that she really values this thing that we talked about last week, what makes her happy or what her life goal is. You know, if something happened where their major medical problem went wrong, what would she want us to do? This gives them the opportunity kind of prepare mentally. Oh yeah, the pneumonia could come back. It becomes a reality. And to show them that you really want to know what is important to them. If things go wrong, the ED doesn't just happen to them. And to answer questions ahead of time instead of the 2 o'clock phone call, they're having a hard time breathing. Can I call 911? You know, oh, they can ask me what happens in the ER. What would they do if my mom doesn't wake up and eat? I'm worried that they're going to put that tube up her nose again. They can express their concerns to you. So it is, you know, once you kind of start narrowing in on the healthcare questions, offer them the space to ask questions about the what ifs. If you feel that at your position on the interdisciplinary team, you don't really have enough background to answer that, be like, you know, I'm not sure, but I do know who could talk to you about this. And that's why as a team, it's really helpful to continue these discussions, to have them start thinking about it, and also to communicate it effectively to the people who could answer very specific questions. I could hand it to Dr. Wen. Maybe she could tell you what happens if they put the tube back in her nose, you know? And I'm gonna text it to her right now. Oh, daughter was asking questions. I was discussing with her this. Or I could write it in my progress note. I sat down to discuss some goals of care. Family had concerns about what if mom doesn't eat? Dr. Wen, would you be able to get back to the family? They have some questions about feeding tubes and what happens if we don't put a feeding tube. And so that communication between the team behind the scenes helps to give the patient and family, build trust that you guys are a functional team and you're all there to kind of answer whatever questions from the right perspectives. Next slide. Who can start the conversation? Does anybody want to, anybody start the conversations on their side? I don't know if I can see the participants. Anybody want to throw up a hand? No? Anybody got good at starting conversations? I don't think I can make a grid right now. It's tough. I do it because I have to, but just know, you don't have to wait for the doc to start the conversation. You know, a lot of this, the big picture stuff starts with building the relationship, showing that we as a healthcare team care about this individual patient. So all of us want to know about Tutu and what's important to her. all of us care about what she wants us to do if something happens, if she falls down again, if she cannot walk. We all want to help her get to the goal of, we know that her goal is to be at home, you know, or at least somewhere close to home where her family can visit. When the whole team kind of shows an interest in learning at least the big picture questions, it really helps to facilitate the conversation. So it's not just a one-on-one scary conversation that only the doctor has with them. It also helps the team to be cohesive in looking at how do we write this care plan to meet the goals and the needs of this patient as an individual. It really puts a lot of your team decisions into perspective as well, not just post-form questions. And so, you know, patients can start the conversation. I've had family members ask me, what do you think? Where are we right now? What happens next? Anyone on the interdisciplinary team. And it's a whole, because it's a team sport, you can always pass the baton to the next person. You're like, you know, I don't know if she'll ever walk again, but I do know that the therapy team can tell you what their process is to work on that. You know, I'll let them know that she wants to know more, or you have questions. Whoever the patient is most comfortable with, and whoever wants to lend an ear. And you know what's nice is, you know, if you've ever had a loved one in any kind of healthcare facility, is when you get the sense from the whole team, everyone around you, that they know a little bit something about your loved one. Like, oh wow, they really got it together. So communication between the team matters a lot. Next slide. When should we, how do you time this conversation? When do we have time to do this? And how frequently should we go back to it? I also have long-term care patients, so some of them have been in my nursing home for years. It's good to introduce yourself and open up the conversation for the big picture when you meet them. So you kind of establish kind of a good base for your relationship. When you do annual visits, anytime there's an acute change in their clinical status, because you're going to have to discuss new options or new concerns. But hopefully we had started off with this bigger picture questions earlier on. So remember when I said I was worried in the future the pneumonia might come back? It looks like it's happening again. So you can kind of, you know, refer back to your past conversations, which is nice. Like, I know you talked to Lori last month when something happened, and she told me that your mom really wanted this specific thing to happen. And I think it's time that we have to talk about it again, you know? So even within the team, that we can revisit and continue for each other. And definitely when there's changes in levels of care, to show that the new team wants to revisit it. Next slide. Sharing what matters. So, you know, how to share is good to have a conversation. It's also very important to document it. Even if it's added in your short progress notes, make sure you communicate important things or big questions or very important questions to the patient, to the rest of your team, so that we can figure out who's the best person to answer these questions. How do we address their needs and concerns? And how does it help us fill out documents that could, you know, be helpful to the team if anything happened? Incorporate into your care plan is really good patient-centered care, so that they also know, like, if I discharge somebody and I send somebody to Dr. Wen's facility, she knows where I left off in the conversation. So even with completely separate teams and completely separate settings, they can pick up where you left off instead of starting all over again. Next slide.
Okay, so I'm going to take over from here. And so, of course, you know, it's really important to make sure, as we talked about in the first session, that everybody has that durable power of attorney. Make sure they named somebody who could help them make decisions in the event that they could not. Advanced Healthcare Directive, as well as the Pulse Form. Next slide. Actually, that's what it is, the numbers, right? So that's number 1, number 2, number 3. These are the 3 kind of important documents to make sure they have in their chart. So make sure that's there. Next slide. And so, yeah, so what we would like you to do, if you don't mind, to please share with us. We're gonna send a link for you to fill out an online survey form to share how many of your residents have these 3 documents. So so have somebody at your facility try to screen all of your residents before our next session. You know, do it this month, do it next month, but please try to do that. So see if they have the power of attorney form. How many have it out of the number of total residents? And advanced care planning, like did they not who it is, but you know, the decisions like you know, whether they want resuscitation or if they want tube feeds or things like that. Those kinds of decisions and out of the total number of residents. And then there's the Pulse form. Next slide. And so over the next, during this whole series, we will provide ideas to help you and your residents complete these forms. And then we'll ask you to do it again at the end of May. And our hope is that the numbers are good and that they're going to get even better. But basically, this will demonstrate that you're doing a good job helping the residents achieve their wishes and, you know, just a focused effort on that. Next slide. Oh, and we just also want to let you know that there are lots of resources out there. Pacoima is a fantastic resource. They're going to join us at our next session next month. And they can answer a lot more questions about the specifics. Next slide. And we also have the little handbook, the legal handbook from the University of Hawaii School of Law. That's UHelp. And we have that available as well as a hard copy or a soft copy if you want to just download that. I will let Michaela talk about how you can get a copy of this.
If you would like a copy of the UHelp book, please send me an email and I will coordinate a time to deliver or have you pick it up from me at Kuakini. I want to enter my email address into the chat box right now. And please reach out if you're on another island. I do have the ability to send you a few as well. I won't be able to send you a big box, but I can send you a few.
Yeah, these you can give out to your families, and that way if they have questions, they can take some time and take a look at that. Next slide. And then I just wanted to give you a few toolkits, you know, all those little questions and things that we showed you earlier, the guides, they're all from this IHI website, Institute for Healthcare Improvement, and they have those toolkit items. So those is a really great website. I'll put that in the chat box as well. There's also resources from the Conversation Project, 5 Wishes and Vital Talks. These are all advanced care planning toolkits for how to have those conversations. And feel free to explore those on your own. Next slide. Okay, so before we end, of course, we want to think about ourselves and think about what matters to us, because we're always so busy worrying about everybody else. So what matters most to you? You know, is it your family, your grandchildren, your church family, your pet, your mango tree, whatever it is, right? So think about it. And, you know, have you been losing touch with that? Or, you know, are you like doing the stuff you want to do with them? And next slide. And think about the things you enjoy. Have you forgotten about them lately? You know, and maybe try to think about doing the things that are most important to you, what matters to you, and try to rejuvenate yourself a little bit, I think so. And maybe do it with the people who are most important to you. So yeah, so these are important to put back into your life. All right, and next slide. And as we talked about last time, Don't forget to plan for your own healthcare as you're thinking about advanced care planning for your patients and your residents. Don't forget your own healthcare, and there's you can fill one out on your own, and there's also that letter project about writing a letter to your doctor about what matters most that might help them know you better as well. And then next slide, we'll have Michaela. Go ahead.
If you have any questions about this as well, you can join me via Zoom, and there'll be a Zoom link in the email that you receive after you complete your evaluation. I will be on at Friday at 10 a.m. and 2 p.m. if you have any questions about the form, or if you, I don't know, if you have any questions about the form and what we're doing with it.
Okay, great. All right, so I'm gonna, let's stop screen share. Oh, yes, thank you for caring, right. May you always have walls for the winds, a roof for the rain, tea for the fire, laughter to cheer you, those you love near you, and all your heart, your might desire. Happy St. Patrick's Day. Anyway, so I'm gonna open up for any thoughts, questions, discussion you have about having these challenging conversations, and maybe you guys want to share any pearls that you have found helpful. Yeah, I just want to agree with Dr. Takenaka that these conversations seem scary at first, but if you just think about it, just talk story, and just find out. I mean, when you get to know somebody new and you make a new friend, what do? You find out what's important to them, right? What makes them tick? What are their passions? And, and then move on from there, and then talk about what they used to do. And it must be hard if you can't do that now. How did you get through these hard times? What gave you strength? All kinds of things. And it gives you this whole context of who they are as a person. And that makes it much easier to segue into these conversations. Dan, you have a question.
Yeah, thank you. Thank you, Ida. Yeah, and thank you, Cody. That was excellent. Well, I just had a little pearl to share, which is that, a lot of times I frame the question where I say, when nothing's going on, when it's not really critical, sometimes these are on routine visits, on a routine visit, I say, when it's not really a serious matter and you're doing well, it could be a good time to talk about what you would think about if it was coming to the end of life, or you were having serious health problems. So that's a good way to walk in that door and sort of frame it in such a way that they know. So you brought up that idea that, why are you talking to me about this? Am I going to die? Is it serious? But you say, when you're alert and you're conscious and you're able to speak for yourself, because that's often the hinge, the pivot point that I emphasize, is that these things don't even come into play unless you can't speak for yourself. Some of those advanced directives. And so I say, well, now, when you're feeling well and we're able to have our conversation, now's a good time to talk about it. And this could be true even in the case of dementia, where somebody is early in dementia and they're, you recognize that during the visit, they're at a time when they're in a lucid period, when they're more likely to be able to, if you're able to recognize that, then you can have that conversation and have some faith that you really have heard what their wishes were, what their interest was, what their advanced directives would be at a period. I think you understand what I mean. If it's early in dementia, then sometimes there's sort of waxing and waning sort of alertness and attention and veracity, if you will. That you can feel confident that you're hearing what they really want to say. So that's a good way to sort of approach that problem that diffuses some of the tone about it. That, you know, we're going to talk about end of life matters because we're worried about your end of life, but no, we're going to talk about end of life matters because explicitly we're not worried about it right now. Explicitly, it's a good time to talk about it when it's not an issue, you know, because
Yep.
when it is an issue, that's a terrible time to talk about it.
Yeah, great idea. I noticed that Leanne Tokushige is on, and she is a palliative care expert, and I think she has probably even more pearls. What's your favorite strategy, Leanne? Are you able to share? Sorry to call on you. Oh, well, maybe later, whenever you want. Love to hear from you.
Oh, sorry, I couldn't find the unmute button.
Oh, okay.
Gee, I don't know. I don't have any special pearls or anything. I just entwine it into my conversation of getting to know the person. I think I was privileged to work with a lot of chaplains, and I'm really impressed the way they approach as opposed to how we are trained. And they walk into situations that, you know, we would all find difficult to be in, like an angry room or something like that. And they say things like, I don't know your mom. This is the first time I'm meeting all of you and your mom, but I really wish I could have known her. I've heard so many good things about her. Can you tell me what kind of person she was? And then the room just magically changes, and everyone is so excited to explain who their mom was, what a wonderful person she was, cooking for like everybody in the community and things like that. And then from there, they go to, you know, the focus now is on the patient rather than themselves and what they are angry about. It's, what do you think, knowing that your mom is this kind of person, what do you think she would want now, the way things, you know, have evolved? So that I kind of like to copy the chaplains. I've been very impressed with their approach.
Great tip. Actually, and I also find social workers are particularly good at this too. Some social workers are really good at it. Okay, anybody else want to share from a facility standpoint? Anybody in the facility start these conversations other than the physician? Anybody? Alice, do you know? Or Yun? How do you, who has these initial conversations, and then how do you pass that on?
Sometimes I even check in with the therapy guys because they do a really comprehensive evaluation and assessment of like their daily life before injuries that ended up in the nursing home with me, or like their occupations. I talked to the aunties in the activities department at my nursing homes because they also do evaluations and assessments of what the patient enjoys with the family or their past hobbies. And it really, learning more about my patients has also helped with kind of stave off a little bit burnout, because you also end up finding joy and, you know, knowing your patient as a person. And when I communicate with the families, I can share that with them. It's like, hey, you know, I saw Mr. So-and-so today and he told me this funny thing, you know, and we enjoy that together. Even though I have to tell them other kind of medical serious updates, that really helps when we have to have more serious conversations or decisions down the line. And it helped me after patients pass away too, that I can share with the families, you know, what we knew about the patient together.
A really good connecting point, a
Yeah.
source of connection. Yeah, it's true. Great. So I think, Michaela or John, if you don't mind, putting in the chat the evaluation information for people to get their CEs and their yeah. Well, Coraline says, I often do it at the end of my social work assessment and just ask if they ever thought about it or what their thoughts are. Some people are very clear and just have never been asked. Thank you very much. Yeah, just start the conversation. Don't be shy. You don't have to be, you know, the thing about advanced care planning discussions, it's not one time. And that's why we call it a conversation, because it's a process. Somebody starts it, somebody continues it, and then somebody else continues it, and then they all talk to each other and it goes on and on. And sometimes that's probably a better way to do it, you know? So I really appreciate when social workers and nurses are part of the team asking. And then sometimes I do that. I start the conversation and then afterwards I call them back. I call the unit floor back and say, hey, or I email them and say, hey, you know, I talked about this and the daughter said she was going to fill out that post form and can you follow up with her and just make so I don't have to be the one chasing all of these things. Right. So things we can follow up and tag team. Great. All right, it's 3 o'clock. Thanks everybody for joining. Any questions, reach out to us. Thanks so much. And we'll see you again next month.
Thank you.